Welcome to the deep dive. Our mission today is focused and pretty vital to really unpack the comprehensive source material you've shared with us on carbon monoxide poisoning. This isn't just about, skimming the literature. It's a deep dive into the nuances, the controversies, and frankly, the clinical realities of what turns out to be a surprisingly common and potentially devastating condition.
Exactly. Yeah, we're looking at excerpts from a really detailed chapter. It takes us right from the fundamental ways carbon monoxide harms the body, through all the complexities of treatment decisions, and then into the long-term consequences that unfortunate patients can face. For you, the specialist clinician listening, our goal is to really distill this wealth of information, highlight the most critical insights, and help build a robust understanding that cuts through some of the noise out there.
Think of us as your navigators, guiding you through the layers of research and clinical experience captured in these pages, ready to dive in and see what stands out.
Let's do it. Let's start right at the beginning with the abstract. It immediately confronts us with the sheer scale of the problem, which I think is often underestimated. Despite all our efforts, establish exposure limits, safety standards, the widespread availability of CA-free alarms. The source estimates that 50,000 people in the United States visit emergency departments each year for carbon monoxide poisoning. 50,000.
50,000, wow, that's a significant number.
It really is. A huge burden on the healthcare system, year after year.
50,000 visits just in the U.S. annually. It truly highlights why this is a topic demanding a deep understanding. And the source quickly establishes that the impact isn't uniform. It depends on the exposure, right?
Exactly. Poisoning can occur from, brief exposures to very high levels of carbon monoxide, or from longer exposures to lower levels.
Yeah.
It's not just about the peak concentration, but the overall dose over time that really matters. And if the carbon monoxide concentration is extremely high, the onset of symptoms can be startlingly rapid. The source points out that with sufficiently high exposure, loss of consciousness can happen quickly, and perhaps most unsettlingly, without symptoms beforehand.
Without warning.
Yeah, you can simply be overcome before you even feel ill.
And that's the dramatic high concentration scenario. But for non-lethal exposures, which are probably more common, typically involving lower concentrations over longer periods, the symptoms are often much less specific. The source lists the common ones: headaches, nausea and vomiting, dizziness, general malaise, altered mental status.
Things that are easily missed.
Right, easily mistaken for the flu, a migraine, or just feeling run down. It makes the diagnosis tricky, doesn't it?
They absolutely can, which is why, maintaining a high index of suspicion is just so important. The source also mentions less common but serious presentations: chest pain, shortness of breath, and even evidence of myocardial ischemia. And in the most severe cases discussed early on, some individuals will require mechanical ventilation and treatment of shock just to survive the initial insult. So the clinical spectrum is vast, from subtle to critically ill.
What really resonated with me, and the source emphasizes this right in the abstract, is the central concept that individuals poisoned by carbon monoxide often develop brain injury. It doesn't pull any punches here. It draws a direct parallel to traumatic brain injury from other causes. The clinical expression of brain injury from carbon monoxide poisoning, just like other forms of TBI, affects domains like cognition, affect neurological function, and somatic complaints. It's not just temporary confusion, it's actual damage to the brain.
And that framing as a brain injury is absolutely crucial for understanding the long-term consequences. The source provides a pretty comprehensive list of the common neurological problems observed, reflecting that widespread impact: imbalance, motor weakness, neuropathies, hearing loss, tinnitus.
It's quite a list.
It is. Parkinson's-like syndrome, vestibular problems affecting balance and dizziness, gaze abnormalities, auditory processing difficulties, cognitive impairments covering everything from memory to executive function, anxiety and depression, post-traumatic stress, changes in personality, persistent headaches, sleep problems, and others. It's clear this isn't a simple transient effect on the nervous system.
And it's not limited to the nervous system either. The source adds that some patients will also have cardiac or other systemic problems, underscoring that while the brain and heart are particularly vulnerable, carbon monoxide is really a systemic toxin affecting multiple organ systems.
Okay, so moving to the initial steps in management, the source introduces the basic principle of oxygen therapy. Breathing oxygen hastens the removal of carboxyhemoglobin from the bloodstream. This is the cornerstone of immediate treatment, right? aimed at displacing the carbon monoxide that's bound to hemoglobin.
Right. Get the CO off the hemoglobin.
But then the source introduces hyperbaric oxygen therapy, or HBO, and this is where we get into the potential for, well, more profound therapeutic effects. It highlights that hyperbaric oxygen not only accelerates carboxyhemoglobin elimination significantly faster than normobaric oxygen.
Much faster.
Much faster, yes. But it also favorably modulates inflammatory processes instigated by carbon monoxide poisoning.
And this distinction is absolutely key, isn't it? The source makes it explicit that this beneficial effect on inflammation is an effect not observed with breathing normobaric oxygen.
Right. That tells us HBO does more than just offload carbon monoxide from hemoglobin faster. It has unique biological actions that might be critical for preventing long-term damage, especially to the brain.
Okay, let's elaborate on those specific mechanisms because they're fascinating.
Yeah.
The source details several ways hyperbaric oxygen is thought to provide benefit beyond just speeding up CO removal. It's described as improving mitochondrial function, essentially helping the cell's energy factories work better.
The powerhouses.
Exactly. It inhibits lipid peroxidation transiently, which is a form of oxidative damage. It impairs leukocyte adhesion to injured microvasculature, part of that inflammatory response where white blood cells stick to damaged blood vessels. And it reduces brain inflammation caused by a specific process involving cheo-induced changes to myelin basic protein. These are complex cellular level interventions.
Yeah, pretty deep stuff. And based on this understanding of the mechanisms and supported by evidence from both animal studies and human clinical trials, the source concludes with a pretty strong statement right there in the abstract. Based upon supportive randomized clinical trials in humans and considerable evidence from animal studies, hyperbaric oxygen should be considered for all cases of acute symptomatic carbon monoxide poisoning.
That's quite definitive.
It is. That's a clear stance from the authors of this material.
And a practical note is added about complicated cases, mentioning that hyperbaric oxygen is indicated for CO poisoning complicated by cyanide poisoning. This is particularly relevant in fire victims, right, where both toxins are often present due to burning synthetic materials, creates a dual threat that HBO might help address.
Absolutely. A very dangerous combination.
Okay, so just to quickly consolidate the core points from this abstract section before we move on, let's do a little micro recap.
Good idea.
We've highlighted the alarming number of ED visits, 50,000 annually in the U.S. We've seen the wide variability in symptoms based on exposure, from subtle to life-threatening. Crucially, we've established that CO poisoning causes brain injury with a broad range of neurological and other sequelae. And we've introduced hyperbaric oxygen as a key therapy that not only speeds CO clearance, but uniquely compared to normobaric oxygen, favorably modulates inflammation and has multiple beneficial cellular actions. This leads the source to recommend its consideration in all acute symptomatic cases, including those complicated by cyanide.
Yeah, that sets a very clear stage for the rest of the discussion.
Okay, let's transition now to the rationale section, starting with where carbon monoxide actually comes from. The source reminds us that our own bodies produce tiny amounts endogenously, as a byproduct of breaking down heme proteins and for signaling functions. But the problem arises from exogenous production.
Right, the stuff from outside. Exogenous CO is produced by the incomplete oxidation, incomplete burning of carbon compounds. When carbon burns completely, you get carbon dioxide and water, pretty harmless. When it burns incompletely due to, say, insufficient oxygen or maybe the temperature isn't right, carbon monoxide is produced. And inhaling this exogenous CO is what causes the toxic or lethal effects.
And the common sources listed by the source are unfortunately ubiquitous in modern life. Gasoline engines in cars, small engines, boats. You think of someone working in a closed garage or using a generator during a power outage, right?
Classic scenario.
Carbon-fueled appliances like furnaces, water heaters, boilers, particularly hazardous if they're faulty or poorly maintained, especially in winter. Charcoal and propane heating and cooking sources deadly if used indoors without adequate ventilation, which we see in emergencies or power cuts. And the source even mentions methylene chloride, a solvent that's metabolized by the body into carbon monoxide.
Yeah, that last one is sometimes overlooked. But a critical factor underscored here is ventilation. Just simply ventilation. Operating any carbonaceous fuel-burning device without proper ventilation, even outdoors in some confined spaces, can lead to dangerous CO buildup. And importantly, a visible flame isn't required for CO production. Smoldering charcoal briquettes or even scored wood pellets can off-gas it. So the potential exposure scenarios are broader than just active burning.
So, in clinical practice, you're thinking about that patient presenting in winter with headache and nausea. Could it be a faulty furnace? The family found unconscious after a storm. Did they use a charcoal grill indoors? The worker with dizziness, were they using a solvent or running equipment in a confined space? The source list gives us concrete scenarios to keep in mind.
Definitely. Moving into the introduction section again, the source reinforces that symptoms manifest when sufficient carbon monoxide is inhaled. It's a dose-dependent effect, but with that caveat we discussed earlier about individual variability and symptoms not matching COHB levels.
The common symptom list is repeated here: headache, nausea, dizziness, lethargy, etc., underscoring their frequency. But again, the source notes it can include many others, just reminding us to be vigilant.
And critically, this section reiterates that vital clinical pearl. Specific symptoms do not correlate with carboxyhemoglobin levels.
Worth saying again.
Absolutely worth hearing more than once because it's so fundamental to diagnosis and management. A normal or low carboxyhemoglobin level does not rule out significant poisoning or the risk of sequelae. You just can't rely on that number alone.
Reaffirming the high-level exposure risk, the source states that at higher levels, loss of consciousness occurs and can be rapidly followed by death. The speed of onset with very high concentrations is a hallmark feature.
And an important kinetic detail for a specific population, children. Because of their smaller size and typically higher minute ventilation relative to body mass, children take up carbon monoxide faster than adults.
Okay.
However, for the same reasons, they also eliminate it more quickly. This difference in kinetics is important to consider in pediatric cases.
The source mentions additional references are available, inviting further reading, which certainly supports the depth we're aiming for in this deep dive.
Now let's turn our attention to the regulatory side in the carbon monoxide exposure guidelines section, referencing Table 1. Various organizations have established limits for human exposure, and understanding these helps contextualize exposure data when it's available.
The primary goal of most occupational limits, as the source explains, is to keep blood carboxyhemoglobin levels below 5% in healthy non-smoking adults over an 8-hour work shift. That's a target specific to a healthy working population.
Right. But the source emphasizes, and this is key, that these occupational limits are not appropriate for the general public or non-occupational circumstances, where you might have more vulnerable individuals, exposed kids, the elderly, people with underlying health issues.
The source provides fascinating historical context with the 1921 Hudson River Tunnel study, referenced as informative about early human experiments with CO exposure.
Quite early work.
And importantly, the source notes that all these recommended threshold levels presume exposure at sea level and apply to healthy, non-pregnant adults. This highlights that they might need adjustment for different populations or environmental conditions.
Altitude, for example, definitely exacerbates the problem. The source explains that the hypoxic effects of CITO will be increased at altitude because the partial pressure of ambient oxygen is already lower to begin with.
Let's look at some examples from Table 1. Maybe not every single number, but focusing on the variation. The World Health Organization has indoor air quality guidelines aiming to keep carboxyhemoglobin below 2%. Their limits vary dramatically with exposure duration. From 86 parts per million for just 15 minutes, that's an excursion limit, down to 9 parts per million for 8 hours and 6 parts per million for 24 hours.
Yeah, it shows how stricter limits are needed for longer exposures, reflecting that cumulative burden, doesn't it?
It does. Contrasting that, the U.S. Environmental Protection Agency deals with outdoor air quality, with limits like a 1-hour average of 35 parts per million or an 8-hour average of 9 parts per million, not to be exceeded more than once a year. That's for ambient outdoor air.
Right, during context. And occupational limits vary too. NIOSH sets an 8-hour time-weighted average at 35 parts per million, while OSHA's enforced 8-hour average is 50 parts per million, after a court vacated a lower rule. ACGIH recommends 25 parts per million. This just illustrates the different approaches even within occupational settings.
And the National Research Council sets limits for highly specific enclosed environments like submarines with a standard of 20 parts per million time-weighted average. Very specific.
Very. And the firefighter example illustrates the altitude effect beautifully. NIOSH proposed reducing the permissible exposure from 35 parts per million at sea level down to 23 parts per million at 5,000 feet and 17 parts per million at 10,000 feet for an 8-hour shift. That directly accounts for the reduced oxygen availability at altitude.
So why are there such differences across these organizations and settings?
Well, it really boils down to the target population, the environment, the expected exposure duration, and the specific goals of the regulating body. Occupational limits are for healthy workers, usually over 8 hours. General population limits have to protect sensitive individuals, including children, the elderly, people with heart or lung disease, and cover potentially longer exposures. Submarine limits are for continuous long-duration exposure in a tightly closed space. They're all balancing risk and feasibility in different contexts.
Okay, that makes sense. To check our understanding of these guidelines based on the source, let's pause for a quick board-style question. According to the World Health Organization guidelines for indoor settings, what is the recommended 8-hour average exposure limit for carbon monoxide, assuming light to moderate exercise?
Okay, looking back at Table 1, that limit is 9 parts per million.
Correct, 9 parts per million.
Yeah.
Understanding these context-dependent limits is important when you're assessing a potential exposure scenario.
Definitely. Okay, maybe time for a bigger recap.
Good idea. Let's do a mega recap on what we've covered so far. We started with the significant prevalence, 50,000 ED visits a year, and the diverse symptoms of CO poisoning, from subtle flu-like feelings to life-threatening collapse. We emphasized that symptoms don't always correlate with carboxyhemoglobin levels, and that children have different uptake and elimination kinetics.
Right. Then we identified the common sources: incomplete combustion from engines, appliances, fires, even solvents, highlighting the critical role of poor ventilation. And we just reviewed the range of exposure guidelines from various organizations, seeing how limits differ based on setting, indoor, outdoor, occupational, submarine, duration, population vulnerability, and altitude, and importantly, why occupational limits aren't suitable for general public health protection.
Okay, moving on to carbon monoxide alarms. The source states these are a vital protective measure against poisoning. Pretty straightforward.
Yeah, but there's often a question about placement, right? High or low. The source clarifies that although CO is slightly lighter than air, its movement in a room is really dominated by diffusion. So the alarms are effective at any vertical location within a room.
Okay, so placement height isn't the critical factor.
Not really. More importantly, the source notes that CO moves readily through drywall, and even homes without a CO-producing appliance still need alarms, because the gas can migrate from attached garages with running vehicles or even adjacent properties like a neighbor's faulty furnace or generator.
However, the source highlights a crucial limitation here. CO poisoning has occurred in homes without a source, specifically due to CO coming in from garages or neighbors. So having an alarm doesn't mean you're completely immune if a neighbor's generator is venting towards your house, for instance.
That's a really important point. And there's a potential issue discussed with the current alarm standard, which requires activation based on mathematical modeling, aiming for a 10% carboxyhemoglobin level. The source explicitly points out why this standard may be inadequate for vulnerable populations.
These vulnerable groups include individuals with heart disease, pulmonary or vascular disease, anemia, or pregnant women. The source suggests that the 10% COHB threshold might simply be too high to protect these individuals who could suffer adverse effects at lower levels or lower ambient concentrations. An alarm with a lower threshold might be more appropriate for them.
Yeah, it makes sense their tolerance would be lower. Furthermore, the source notes that repetitive exposures to CO at levels below the alarm threshold can still cause harm. This speaks to the risk of chronic or subthreshold exposure, something the current alarm standards don't really fully address.
Table 2 in the source details the required alarm response times based on concentration. For example, at 30 parts per million, an alarm shouldn't go off for 30 days, presumably to avoid nuisance alarms from very low transient levels. But at 70 parts per million, it must alarm within 60 to 240 minutes. And at 400 parts per million, it has to alarm within just 4 to 15 minutes. These times reflect the increasing urgency with higher concentrations.
So thinking about why the standard might be inadequate for vulnerable populations, it seems to be about their reduced physiological reserve, or perhaps increased susceptibility to oxidative stress or hypoxemic effects at lower COHB levels than healthy individuals.
Right. And how could repetitive low-level exposure cause harm?
Well, likely through cumulative cellular injury, ongoing oxidative stress, or maybe low-grade inflammation that just builds up over time. Even if individual exposures are below that acute alarm threshold, it's death by 1,000 cuts, maybe.
Okay. Let's delve deeper now into clinical manifestations, dose, duration, and latency. The source reiterates that very high concentrations, we're talking greater than 10,000 to 20,000 parts per million, can cause rapid death, potentially without symptoms or with just a quick loss of consciousness. That's the sudden collapse scenario we mentioned.
Yeah, terrifyingly fast. but exposure for several hours to concentrations of 500 to 1,000 parts per million can also be lethal. This shows the cumulative effect over time with lower but still quite high concentrations.
The common symptoms, headaches, nausea, and so on, are listed again, emphasizing their presence at lower ambient concentrations. But the source adds that some patients will have more severe presentations requiring critical care, like chest pain, myocardial ischemia, mechanical ventilation, and shock treatment. The whole spectrum.
And a key concept introduced here is the potential for occult carbon monoxide poisoning. The source states that poisoning can occur from brief high exposures or longer low exposures, but some patients with occult poisoning have symptoms that manifest weeks, months, or even years later.
Weeks, months, or years later, that gives us a critical clinical pearl, doesn't it? For anyone evaluating patients with unexplained, chronic, or delayed neurological or systemic symptoms, you have to consider CO poisoning, especially if there's any plausible, even seemingly minor or remote exposure history. Those chronic headaches, dizziness, or cognitive issues could absolutely be the result of an exposure months ago that was initially dismissed or attributed to something else entirely.
Exactly. It needs to be on the differential, even much later.
Okay, now let's move into the fundamental problem, the pathophysiology of carbon monoxide poisoning. The source starts with the classic mechanism we all learned. CO preferentially binds to hemoglobin, much higher affinity than oxygen, forming carboxyhemoglobin. This reduces the blood's oxygen carrying capacity and shifts the oxygen-hemoglobin dissociation curve to the left, making it harder for hemoglobin to release the oxygen it is carrying to the tissues. The source also notes that CO diffuses into extravascular tissues.
Right, that's the textbook picture. But this is where the source significantly expands our understanding beyond just oxygen displacement. It emphasizes that CO also binds directly to heme proteins within cells, such as cytochromes, which are essential for cellular energy production in the mitochondria. This binding interrupts cellular metabolism directly.
And here's the crucial distinction emphasized by the source. The interruption of cellular metabolism by CO is described as being more injurious by mechanisms other than hypoxia. Similarly, neuronal injuries are stated to arise by mechanisms other than hypoxia.
But it's not just suffocation.
Exactly. It challenges the traditional view that CO poisoning is simply cellular suffocation due to lack of oxygen delivery. It's a direct cellular toxin as well.
Yeah, and this deeper understanding leads to the complex cascade of biochemical events underlying the neuropathology. The source notes that these involve several immunological and inflammatory pathophysiologic processes that can evolve over weeks, causing those delayed sequelae we just discussed.
The source gets quite specific about some of these mediators. Endothelial-derived and astrocyte-derived microparticles are proposed as potentially initiating a subsequent cascade of immunological effects. Little packets of trouble being released.
And there's differential vulnerability among brain cells. The source mentions in vitro research showing oligodendrocytes, those are the cells that form myelin, are more susceptible to CO's toxic effects than other brain cell types. This might help explain the white matter damage seen in some severe cases.
Oxidative stress is another key player identified. CO toxicity is triggered by oxidative stress from reactive oxygen species generated during this cellular disruption, like internal rusting.
Good analogy. The source adds that CO poisoning may also produce cellular injury by sort of deregulating and interacting with nitric oxide and hydrogen sulfide signaling pathways. It's messing with the cell's communication systems, too.
Interestingly, some observed biochemical changes are stated to be independent of poisoning severity, suggesting that even seemingly mild exposures might trigger some of these harmful cellular pathways, although perhaps to a lesser extent clinically.
Okay, let's try to visualize this pathophysiology beyond just the hemoglobin effect. Imagine CO entering the body. Yes, it binds to hemoglobin in red blood cells, reducing oxygen transport. That's definitely happening.
Okay.
But simultaneously, CO molecules are diffusing out of the blood and into the tissues where they find their way into cells, particularly into the mitochondria, the powerhouses of the cell. Inside the mitochondria, CO binds directly to key enzymes, like cytochrome C oxidase, that are essential for the final steps of aerobic respiration, turning nutrients and oxygen into energy, into ATP. By gumming up this machinery, CO directly inhibits cellular energy production, irrespective of how much oxygen is actually available.
So it shuts down the power plant directly.
Pretty much. And this direct attack on cellular energy, combined with CO triggering oxidative stress, your roasting analogy, and potentially interfering with cell signaling molecules, sets off a chain reaction. This chain reaction involves inflammation, immune cell activation, damage to cell structures like myelin,
Hmm.
and this can continue even after the CO is gone.
So that explains why the injury isn't just about the acute lack of oxygen, but involves ongoing cellular dysfunction and damage.
Precisely. It's this multifactorial attack on cellular processes, especially energy production and inflammation, that explains the depth and duration of the injury, particularly to metabolically active tissues like the brain and heart.
Okay, quick micro recap on the pathophysiology then. While carboxyhemoglobin formation and oxygen displacement are classic, the source emphasizes that the most injurious mechanisms involve CO's direct binding to tissue heme proteins, like cytochromes, inhibiting cellular metabolism and ATP production. This triggers complex inflammatory and oxidative stress cascades, disproportionate to simple hypoxia. Specific cells like oligodendrocytes are vulnerable, and these processes evolve over time, leading to delayed sequelae.
Nicely summarized. Let's move to organ susceptibility and cardiac injury, identifying the prime targets. The source states the two organ systems most susceptible to injury are the cardiovascular and central nervous system. Makes sense, given their high energy demands.
A point we've touched on but bears repeating because it's so counterintuitive. The source explicitly states that the carboxyhemoglobin level is not predictive as a risk factor for CO-mediated morbidity or mortality. You cannot rely on that number alone to predict who will do poorly.
Yeah, gotta hammer that one home. Animal models provide some insights into complex interactions. In some models, both co-mediated hypoxia and decreased blood flow from a cardiovascular insult are needed to cause CNS damage. However, the source notes that in humans, loss of consciousness is not required for cognitive sequelae. You don't need that marker of profound acute insult to have brain damage later on.
Animal studies also show effects at relatively low doses. Exposure to 50 to 90 parts per million for just 60 minutes caused vascular oxidative stress in animals. And a study exposing dogs to 50 pChem for 6 hours a day for 6 weeks resulted in brain and heart pathology. This reinforces that duration and even lower levels can cause measurable organ damage over time.
Regarding cardiac injury, human and animal data suggest that major cardiac injury at the time of poisoning is primarily due to CO-induced hypoxic stress. So, acute heart problems seem linked more to the oxygen deprivation aspect.
However, the source discusses longer-term cardiac risk. CO may increase the risk for cardiovascular-related death over the 10 years following injury, especially if they had acute cardiac injury. Though another study mentioned points to psychosocial factors or accidents being more likely causes of increased long-term mortality. So a bit of conflicting data there.
Yeah, not entirely clear-cut. The source highlights specific long-term cardiac changes noted in the literature, though, such as reductions in left ventricular and diastolic function years later and myocardial fibrosis. This suggests the damage can be structural and persistent, quoted from an editorial apparently.
The data on mid-wall myocardial injury, possibly from direct CO toxicity beyond just hypoxia, is called particularly compelling by the source, expanding on earlier case reports. This supports the idea of CO as a direct cardiotoxin, not just causing damage via hypoxia.
Given the risk of myocardial injury, the source provides specific assessment recommendations. Troponin person is listed as a crucial screening test. However, echocardiography may give false reassurance. Therefore, cardiac magnetic resonance, or CMR, should be the imaging modality of choice for initial assessment and follow-up in patients with suspected myocardial injury.
Okay, that's a very clear, specific clinical recommendation.
It is.
So to circle back, why isn't carboxyhemoglobin a good predictor of outcome again?
Because the injury isn't just about oxygen deprivation. It's about that direct cellular toxicity, the inflammation, the oxidative stress, mechanisms that aren't directly reflected in the amount of CO bound to hemoglobin at one point in time. The COHB level is a marker of exposure at acute oxygen disruption, sure, but not the extent of the underlying cellular damage or the intensity of that inflammatory cascade that follows.
Right. And differentiating a key hypoxic cardiac injury from longer-term structural changes like fibrosis is key. Acute damage is likely tied to initial oxygen deprivation, while fibrosis might be a consequence of those ongoing or delayed cellular and inflammatory processes.
Exactly. Two different phases of injury, potentially.
Okay, let's pose a board-style question based on this. A patient presents after CO exposure with symptoms suggesting cardiac involvement and an elevated troponin boil. According to the source material, what imaging modality should be the choice for initial assessment and follow-up of myocardial injury in this patient?
Based on what we just discussed, the source specifies that cardiac magnetic resonance, or CMR, should be the imaging modality of choice.
Correct. CMR. That's a key takeaway for clinical practice from this source.
Definitely. Now let's delve into the extensive realm of brain injury and long-term neurological sequelae. The source reiterates the core point. Just like other brain injuries, CO poisoning impacts cognition, affect, leads to somatic complaints, and neurological deficits.
The common sequelae are a wide spectrum, covering cognitive issues, high rates of anxiety and depression, persistent headaches and dizziness, sleep problems, motor weakness, vestibular and balance problems, peripheral nerve damage, hearing loss, tinnitus, and Parkinsonian-like features. It's clear the impact on the nervous system is broad and potentially disabling.
Yeah, quite a list. An interesting detail about the Parkinson's-like syndrome is that the source notes it presents differently on FDOPA PET scans compared to idiopathic Parkinson's disease, offering a potential diagnostic distinction, which is clinically useful.
Neuropsychological testing is mentioned as common following poisoning, as it's really the tool to objectively measure some of these cognitive and affective deficits, isn't it?
It is. The source specifically highlights the high incidence of anxiety and depression and notes that these affective symptoms may not be favorably influenced by hyperbaric oxygen. This suggests that maybe different pathways are involved for those affective symptoms, or perhaps they're less amenable to HBO therapy for some reason.
Now, let's look at the truly sobering findings from long-term follow-up studies mentioned. Carbon monoxide poisoning significantly increases the risks, months to years later, for a surprisingly extensive list of chronic medical conditions: epilepsy, diabetes, hypothyroidism,
It just keeps going.
peripheral and cardiovascular disease, heart failure, strokes, adrenal insufficiency, the Parkinson's-like syndrome, multiple sclerosis, various other nervous system diseases, including sleep issues, headaches, anoxic injury, post-exhaustive neuralgia, acute and chronic kidney injury, and sadly, increased risk of interval death and suicide.
That list is profound. It really speaks to the systemic and enduring impact of CO poisoning far beyond the initial event. It's not just about surviving the acute phase, it's about managing a significantly elevated risk for numerous chronic diseases and mortality for years afterward. The need for comprehensive long-term follow-up care just jumps out from this data.
Absolutely. Just to quickly recap the brain injury and long-term sequelae, we've reinforced that CO causes true brain injury with wide-ranging symptoms, including high rates of affective disorders like anxiety and depression that might not respond well to HBO. Critically, we've highlighted the extensive list of chronic medical conditions and increased mortality risks that patients face for years after poisoning, underscoring the importance of long-term follow-up and multidisciplinary care.
Well put. Let's shift focus now to the elimination half-life of carboxyhemoglobin and oxygen therapy. The source confirms that breathing oxygen speeds up the removal of CO from hemoglobin. Pretty basic. However, the half-life of COHB when breathing air at sea level is noted as variable. It's not just one fixed number.
Right. The source provides several specific data points showing this variability, ranging from biphasic curves in sheep, an initial faster phase, then a slower one, to studies in tonometered blood in dogs showing half-lives from around, 3 to 5 hours, like 188 to 320 minutes?
Yeah, quite a range. And the variability in half-life is explained by physiological factors. Since CO is eliminated through ventilation and pulmonary blood flow, things like lower alveolar ventilation or reduced cardiac output will naturally lengthen the elimination half-life. A sicker patient, for instance, might clear CO slower.
With administration of normobaric oxygen, that's pure oxygen at sea level pressure, the COHB half-life in poisoned adults is significantly reduced to around 74 minutes, plus or minus 25 minutes, so a bit over an hour on average. This is the basis for standard oxygen therapy.
The source also mentions data comparing oxygen delivery methods. High-flow nasal cannula administration of oxygen may lower the COHB elimination half-life even further compared to a standard non-rebreather mask. One study showed a half-life of around 41 minutes with HFNC versus 64 minutes with a non-rebreather. That was statistically significant, so faster clearance might be possible with higher flow systems.
Faster is better, right? Well, maybe not necessarily for the long term. The source has a crucial caveat. These studies comparing oxygen delivery methods did not provide long-term outcomes. Therefore, it is unknown if more rapid removal of COHB using methods like high-flow nasal cannula actually improves the patient's long-term outcome. Faster clearance of COHB doesn't necessarily translate to preventing those delayed neurological sequelae, which aligns with the understanding that the injury is more than just the COHB binding itself.
Right, it comes back to those other mechanisms. So why are there such wide ranges in reported half-lives, especially in the air-breathing studies? It's likely a combination of things, species differences in the animal studies, variability in experimental conditions like breathing patterns, and just inherent biological variation in human ventilation and cardiac output between individuals.
And the clinical implication of faster COHB removal without proven long-term outcome benefit is that while getting the number down faster might seem intuitively better based on this source, we don't have solid evidence that it changes the ultimate prognosis regarding those devastating neurological problems. It's a means to an end reducing COHB, but maybe not the sole determinant of recovery.
Exactly. Which brings us back nicely to hyperbaric oxygen, HBO, rationale and mechanisms, building on our initial introduction. The source reiterates the well-established effect. HBO dramatically accelerates COHB dissociation compared to breathing pure oxygen at sea level pressure. At higher pressures, the partial pressure of oxygen is significantly increased, driving the CO off hemoglobin much, much faster.
But again, the source strongly emphasizes that additionally, and this is the really key part, hyperbaric oxygen, but not ambient pressure oxygen, has several actions that are beneficial in ameliorating nervous system injuries. This is the unique value proposition of HBO, according to this source.
Yes. The source details the specific proposed mechanisms for HBO's neurological benefits, drawing from that complex pathophysiology we discussed. These include improving mitochondrial function, inhibiting lipid peroxidation, impairing leukocyte adhesion to injured microvasculature, reducing brain inflammation related to damaged myelin basic protein, and increasing red blood cell deformability. These are the non-COHB mediated effects.
And animal data supports these multimodal benefits. Animals treated with HBO show faster improvement in cardiovascular status, lower mortality, and a lower incidence of neurological sequelae compared to those treated with just normobaric oxygen.
Table 3 in the source provides a detailed list mapping. CO pathophysiology points to how HBO favorably influences them. We don't need to read every line, but let's verbally describe some key areas where HBO exerts its unique benefits. Beyond just rapid COHB clearance, HBO provides sufficient dissolved oxygen in the plasma to bypass the need for oxygen-carrying hemoglobin, helping normalize tissue oxygenation. It reverses CO binding to cellular proteins like cytochromes. It helps preserve cellular energy production, ADP, and triggers protective oxidative stress responses. It boosts the body's own antioxidant defenses. It helps modulate inflammation by reducing leukocyte adhesion. It can prevent lipid peroxidation and mute the inflammatory response to myelin damage. It can also help reduce neuronal cell death.
So this walkthrough really reinforces that HBO isn't just about pushing CO off hemoglobin. It's intervening at multiple points in that downstream injury cascade, supporting cellular energy, dampening inflammation, fighting oxidative stress, protecting vulnerable cell structures. This helps explain why it might improve neurological outcomes in ways normal baric oxygen simply can't.
Exactly. And the source quotes Sutherman and Tom, summarizing the strength of the evidence for this approach. We conclude that there is an abundance of basic science and preclinical and clinical research supporting the use of hyperbaric oxygen for acute carbon monoxide poisoning. Pretty clear statement.
Okay, let's test our understanding of these unique benefits again. According to the source, hyperbaric oxygen ameliorates nervous system injuries via several mechanisms not observed with normobaric oxygen. Can you list at least 3 such mechanisms described?
Sure. Based on the source in Table 3, 3 mechanisms unique to HBO would be improving mitochondrial function, inhibiting lipid peroxidation, and impairing leukocyte adhesion to injured microvasculature. You could also mention reducing brain inflammation related to myelin damage or regulating gene expression related to dopamine pathways.
Excellent. It's these specific effects that are thought to drive the improved neurological outcomes seen with HBO in some studies.
Right. Let's consolidate our understanding of HBO thus far in another mega recap. We've confirmed HBO accelerates COHB clearance, but the critical insight is its unique non-COHB mediated benefits. We've discussed these proposed mechanisms, including improving mitochondrial function, inhibiting oxidative stress and inflammation, and protecting myelin. Animal studies support improved outcomes with HBO, and the source authors find an abundance of evidence supporting its use for acute CO poisoning. This mechanistic understanding is really key to appreciating why it's recommended for neurological protection.
Now for the practical question. Patient selection criteria for hyperbaric oxygen. Who gets it? The source provides clear primary criteria for referral. Patients showing signs of serious poisoning, defined as any period of transient or prolonged unconsciousness, definite neurologic signs, like focal weakness, gait abnormalities, visual changes, clear cardiovascular dysfunction, like ischemia, arrhythmias, or severe acidosis. These patients, the source states, should be referred for hyperbaric oxygen regardless of their carboxyhemoglobin level. Symptom severity, especially neurological and cardiac involvement, is paramount for selection here.
Yeah, clinical picture trumps the number. Epidemiologic studies provide prognostic indicators, suggesting poorer outcomes for patients with underlying cardiovascular disease, those older than 60 years of age, those who experienced any period of unconsciousness, or those presenting with severe acidosis. These are risk factors for worse prognosis overall, which might further support considering HBO.
The source reiterates, again, that despite common belief, the COHB level does not correlate with the severity of signs and symptoms, nor does it predict the development of neurological or cognitive sequelae. However, referral for HBO is still considered reasonable practice for patients with COHB levels greater than or equal to 25%, even if symptom severity is less pronounced. It's a common threshold used in practice, though not the primary driver for severe cases.
Describing typical practice among hyperbaric physicians, the source notes that a majority will offer HBO even for patients with less severe symptoms if COHB levels are elevated, generally in the range of 25 to 30%, or maybe if neuropsychological testing is abnormal. However, the source adds that the role of neuropsychological tests in acute patient selection for HBO therapy is not clearly established.
The source references a study that looked at risk factors for 6-week cognitive sequelae in patients not treated with HBO. On initial univariate analysis, age 36 or older, loss of consciousness, COHB levels 25% or higher, or exposure lasting 24 hours or more were associated with increased risk if HBO was not used.
But here's where it gets interesting. In a multivariable analysis from the same study that included patients who did receive HBO, those 36 years or older who were treated with hyperbaric oxygen had reduced 6-week cognitive sequelae rates.
So HBO might mitigate that age-related risk factor.
It suggests that, yeah, the study, however, was underpowered to assess HBO's effects specifically on those with longer exposure durations, like over 24 hours.
Cerebellar dysfunction, assessed by simple neurological tests like finger-to-nose or gait testing, might also indicate increased risk for cognitive sequelae, according to the source.
Importantly, though, the source states that hyperbaric oxygen can reduce 6-week cognitive sequelae in patients with or without initial cerebellar dysfunction, meaning you don't need this specific sign to consider HBO. Conversely, the absence of cerebellar abnormalities shouldn't stop a physician from using HBO if other criteria are met.
But there's a caveat.
There is. The source adds that this link between cerebellar dysfunction and later outcomes wasn't confirmed in another trial, introducing some uncertainty there.
A key takeaway regarding prognosis. The source states that no single risk factor is predictive of long-term outcome. This underscores the complexity and the difficulty in predicting who will ultimately do poorly.
And findings from another study mentioned are really notable. Individuals without loss of consciousness and with COHB levels less than 15% still had the same risk for cognitive sequelae at 1 year as those with higher COHB levels or loss of consciousness.
Wow. So even seemingly mild cases are at risk long-term.
Exactly. It strongly supports treating based on suspicion and potential for injury, even in seemingly milder cases, because that long-term risk exists across the spectrum.
The source also notes that even mildly poisoned patients show numerous biochemical changes in blood, aligning with the idea that the underlying cellular injury cascade is triggered even in less severe presentations.
A fascinating, though currently not really clinically applicable point is the mention of the apolipoprotein E4 allele ApoE4, a genetic marker associated with worse outcomes after brain injury generally. Research suggested non-carriers might respond better to HBO after CO poisoning, but this allele is only present in a minority of the population, genetic info isn't available acutely, and another trial couldn't confirm this finding anyway. So it's an interesting research avenue, but not a clinical selection tool right now.
Okay, pulling all this together, the overarching recommendation from the source stated definitively. Based on all the above factors, hyperbaric oxygen should be considered for all cases of acute symptomatic carbon monoxide poisoning. This prioritizes the potential benefit for preventing sequelae, given the significant risk across a range of presentations.
Yeah, it's a broad recommendation. Now, why is loss of consciousness such a strong indicator for HBO referral, even if COHB doesn't predict outcome?
Well, likely because it's a clear, objective sign of significant acute physiological derangement, right? It suggests the dose and impact were sufficient to overcome consciousness, making downstream injury highly probable, even if the COHB has come down by the time they're assessed.
Makes sense. And the controversy around using COHB levels for selection stems from the data showing poor correlation with outcome and risk across a range of COHB values, including low ones. While a high number might feel alarming, the source suggests focusing on clinical signs of injury is more important for predicting who needs HBO to prevent those long-term issues.
Right. The ApoE4 finding is a great example of how genetic factors might influence response. But until confirmed and readily available, it remains a research curiosity, not a guide for acute treatment decisions.
Okay, here's a board-style question for you. According to the source, what are some key clinical indicators prompting consideration of hyperbaric oxygen therapy for a patient with CO poisoning, regardless of their initial carboxyhemoglobin level?
Let's see. The source lists transient or prolonged unconsciousness, definite neurologic signs, cardiovascular dysfunction, and severe acidosis as key indicators prompting consideration for HBO, regardless of the COHB level.
Perfect. Clinical severity drives the decision in this source.
Okay, let's do a mega recap on patient selection for HBO. The source advocates considering HBO for all acute symptomatic cases. Strong indicators for referral are signs of serious poisoning, like unconsciousness, neurodeficits, cardiac issues, or severe acidosis independent of the COHB level. While a COHB above 25% is a common practice threshold in less severe cases, the source stresses COHB level is not a reliable predictor of outcome. Age over 60 and LOC are risk factors, which HBO might mitigate. Cerebellar signs are potential indicators but not definitively linked across all studies. The ApoE4 allele is interesting but not clinically useful yet. The overall recommendation leans towards treating based on clinical presentation and the potential for significant long-term sequelae.
Nicely done. Now let's discuss clinical management oxygen therapy and HBO protocols.
Okay.
Basic initial treatment starts with administering supplemental oxygen at high concentrations, typically via a non-rebreather mask or maybe high-flow nasal cannula. This is recommended to hasten COHB dissociation and improve tissue oxygenation.
Standard stuff. However, the source notes a lack of evidence from clinical trials demonstrating improved long-term outcomes solely from normobaric oxygen therapy. While it's the standard initial treatment and biologically sound for COHB clearance, its impact on preventing those delayed neurological issues hasn't been proven in the trials presented here.
Yeah, that's an important point. Regarding hyperbaric oxygen dosing, the source states that the optimal pressure, duration, and frequency are not definitively known. This is an area of ongoing uncertainty and debate in the field. However, the source suggests that the optimal benefit from HBO likely occurs with the least delay after exposure. Timing is believed to be critical.
The source contrasts common practice with evidence. The majority of hyperbaric facilities provide a single hyperbaric oxygen session. However, the source notes that in selected patients, repeated treatments may yield a better outcome than a single treatment, hinting at a potential gap between typical practice and protocols used in trials that actually showed benefit.
Right. The source describes two specific protocols used in randomized trials that did show improved outcomes. One involved an initial compression to 3 atmospheres absolute, ATA, then 2 ATA for 140 minutes, followed by 2 additional sessions at 2 ATA for 90 minutes each, within 12 hours, using air brakes to prevent oxygen toxicity. That's a multi-session, relatively high-pressure initial protocol.
Okay, 3 sessions total, starting high.
Yeah. The other protocol mentioned involved initial compression to 2.8 ATA, then 2 ATA for 120 minutes, without further hyperbaric oxygen. This represents a single-session approach at a slightly lower initial pressure.
The source discusses a blinded, randomized trial that compared the first protocol, 3 sessions, to patients receiving only the first session of that protocol. This trial found no difference in cognitive sequelae rates between the 1-session and 3-session groups at 6 weeks and 6 months.
Which seems counterintuitive, right?
Yeah.
If 3 sessions worked in the original trial.
Exactly. But the source notes this comparative trial was limited to non-intubated English-speaking patients at a single site, which might limit generalizability. Maybe it wasn't the right population or setting to see the difference.
Could be. Beyond oxygen and HBO, medical management is discussed. Recommendations include obtaining an electrocardiogram and serial cardiac enzyme measurements, like troponin I, due to the risk of myocardial injury. If cardiac injury is evident, further evaluation and follow-up are advised, keeping in mind the potential for long-term issues like reduced ventricular function and fibrosis we talked about.
Okay, let's talk about what atmospheres absolute means in practical terms. 1 ATA is the pressure at sea level, about 101 kilopascals. 2 ATA is twice that pressure, like being 10 meters or 33 feet underwater. And 3 ATA is 3 times sea level pressure, like being 20 meters or 66 feet underwater. Increasing the pressure dramatically increases the partial pressure of oxygen, forcing it to dissolve directly into the blood plasma. This dissolved oxygen can then bypass the COHB-saturated hemoglobin and deliver oxygen directly to tissues.
Right, it's using pressure to dissolve more oxygen. And the clinical trade-offs in HBO protocols, frequency, duration, pressure. Well, higher pressures might have stronger anti-inflammatory or mitochondrial effects, as suggested by that mechanistic data needing over 2 ATA for maximum inhibition of leukocyte adhesion. More sessions might be needed to address ongoing inflammatory or cellular injury processes that don't resolve after just one treatment. But logistics, cost, patient tolerance, chamber availability all play a role. And the optimal combination isn't definitively established, leading to the varied practice we see.
Makes sense. Here's a board-style question. According to one randomized trial protocol mentioned in the source that showed improved outcomes, what initial pressure was used, and how many total hyperbaric oxygen sessions were administered in that protocol?
Okay, according to the first protocol described, the one that showed benefit, the initial pressure was 3 atmospheres absolute, and a total of 3 hyperbaric oxygen sessions were administered.
Correct. That's the protocol from the key HBOT 12 trial.
Okay, let's do a mega recap on clinical management and protocols. Normobaric oxygen is standard initial care, improving COHB clearance but without proven long-term outcome benefit in trials cited here. For HBO, optimal dosing is unknown, but earlier treatment is thought to be better. While most centers do 1 session, some evidence, specifically HBOT 12, supports 3 sessions within 24 hours starting at higher initial pressures, 3 ATA, for reduced neurological sequelae. However, another trial comparing 1 versus 3 sessions didn't show added benefit, adding to the uncertainty. Routine cardiac assessment, particularly with troponin I and potentially CMR, is crucial. We've outlined the general approach and the ongoing debate surrounding optimal HBO delivery based on this source.
Moving into outcomes, long-term problems, and specific populations, the source confirms that even with hyperbaric oxygen treatment, some patients will still develop neuropsychological or other adverse sequelae. The incidence is reduced by HBO, but it's not a guaranteed prevention of all long-term issues.
Yeah, it's not a magic bullet. More sophisticated neuroimaging and neuropsychiatric assessments reveal that some cognitive and cerebral vascular abnormalities can persist even after aggressive therapy, although less frequently with HBO treatment. This confirms that permanent changes can indeed occur.
The source strongly emphasizes the necessity of follow-up for poisoned patients and referral to appropriate resources for those with sequelae. Given the potential for delayed or persistent problems, ongoing care is vital.
Specific populations have unique considerations. Children with CO poisoning can be safely treated with hyperbaric oxygen, but like adults, they can unfortunately have long-term problems.
A small study in children found that while they had average neuropsychological test results at 6 weeks and 6 months, many still had symptoms suggesting CO-related problems, and most had vestibular and balance abnormalities consistent with brain injury.
That's a really crucial point.
Right.
Normal standard test scores in children might not capture all functional issues or subtle deficits, particularly in areas like balance or maybe executive function as they get older.
So that might explain why children can have long-term problems despite initially normal tests. The tests might not be sensitive enough, or the injury might evolve, or subtle deficits only become apparent as they grow and face increasing cognitive demands.
Exactly. It highlights the need for thorough, probably functional assessments beyond just standard cognitive tests in kids.
The source addresses the critical issue of teratogenicity during pregnancy. Carbon monoxide poisoning can harm the developing fetus, especially in serious cases. Modeling from animal experiments suggests fetal COHB half-life is 1.5 times longer than the adult half-life.
Meaning the fetus is exposed for a longer duration for any given maternal level.
Right. One study on fetal outcomes suggested mild exposures are likely okay, but severe poisoning carries serious risk to fetal viability and development. The study also indicated that hyperbaric oxygen may decrease fetal hypoxia and improve outcome.
Based on this, the source recommends treating pregnant women with hyperbaric oxygen for acute CO poisoning, stating it can be done safely without fetal harm. And interestingly, if there are signs of fetal distress, HBO may even be considered if the mother is asymptomatic, prioritizing fetal well-being.
The source introduces a glimpse into the future with a potential novel agent, a human-engineered neuroglobin designed to displace CO from hemoglobin, with the CO then excreted by the kidneys. This agent, not yet approved for human use, showed incredibly rapid COHB reduction in vitro and faster elimination than 100% oxygen in mice.
Sounds promising, but
But the source notes its limitations. It hasn't been tested in humans and may not address the immune-mediated aspects of poisoning. Clinical trials are obviously needed to assess its safety and efficacy.
right, a potential tool for the future, but not here yet.
Okay, quick micro recap on this section. We've seen that sequelae can occur even with HBO, and long-term follow-up is essential. Children can have long-term issues, possibly subtle ones like balance problems, even with normal early testing. CO is terogenic, and HBO is recommended for pregnant women, possibly even if the mother is asymptomatic due to potential fetal benefit. And finally, neuroglobin is a fascinating but still experimental future therapy.
Got it. Moving into long-term follow-up and persistent problems, the source strongly reiterates the need for ongoing follow-up after discharge. Patients may have persistent issues or develop new ones weeks to months later, highlighting the delayed nature of some sequelae.
Common persistent complaints listed in long-term studies include headaches, dizziness, imbalance, fatigue, sleep disturbance, and neuropsychological and affective symptoms, often similar to post-concussive syndrome. Unfortunately, treatment for these persistent symptoms is often just supportive care.
Specific follow-up is needed for cardiac problems that may require intervention, reinforcing the need for cardiac assessment we discussed earlier.
Studies following patients for a year and beyond document adverse effects on cognitive function, quality of life, and general health, confirming a significant long-term burden from SIGO poisoning.
Specific study findings underscore this. A 3-year follow-up study found 11% of patients had gross neuropsychiatric sequelae directly linked to the poisoning, while 30 to 40% had memory, personality, or affective changes. Significant numbers.
Another study following patients for a mean of 6 years found 13 to 19% had cognitive impairments and 38% had neurological deficits. Again, substantial rates of persistent problems years later.
And data from a very long-term study following survivors of a mining accident for over 30 years is particularly striking. 69% still showed cognitive dysfunction, and 83% of those who had brain MRIs showed structural neuroimaging abnormalities.
Decades later. Wow, that emphasizes that the brain injury can be permanent and persist for decades, often visible on imaging.
Yeah, truly sobering. Reiterating a point from earlier, the source confirms that CO poisoning increases the risk for developing that wide array of chronic disorders we listed before.
Does HBO help long-term outcomes? The source notes that those treated with hyperbaric oxygen have reduced short-term and long-term mortality. A large retrospective analysis showed reduced inpatient and 1-year mortality with HBO. So yes, it seems to help with survival.
The source briefly mentions HBO use weeks, months, or years after poisoning for persistent sequelae. Case reports and series suggest potential benefit, but randomized controlled trials are lacking for this delayed treatment scenario. In this context, HBO is used to treat the brain injury itself, which the source suggests is analogous to how HBO is sometimes used for other types of brain injury in a subacute or chronic phase like TBI or stroke rehab in some centers.
Okay, so let's elaborate on the clinical implications of these persistent and delayed issues. It means initial recovery is not a guarantee of long-term well-being, right? Patients need to be warned about potential delayed problems. Clinicians need to be prepared to evaluate for and manage chronic headaches, dizziness, fatigue, sleep disorders, and persistent cognitive or affective issues, often requiring referral to neuropsychology, rehabilitation, or psychiatry. The high rate of structural changes on imaging decades later just underscores the potentially permanent nature of the injury in many cases.
Absolutely. Vigilance is key.
Let's pose a board-style question about extreme long-term outcomes. According to the source, what percentage of survivors in the long-term follow-up study of a mass casualty mining accident showed cognitive dysfunction in more than 30 years after exposure?
That striking number was 69%.
Correct. 69%. A clear demonstration of the enduring impact.
Okay, mega recap for long-term follow-up. Persistent and delayed problems are common, even with HBO, and long-term follow-up is essential. Common complaints are similar to post-concussive syndrome. Long-term studies document high rates of cognitive impairment and neurological deficits years to decades later, often with structural brain changes. CO poisoning increases the risk for numerous chronic diseases and long-term mortality. While HBO reduces short-term mortality and likely improves long-term outcomes compared to normal baric oxygen, evidence for using HBO weeks or months later for persistent sequelae is limited to case reports and series.
Okay, now, the evidence-based review of hyperbaric oxygen, HBO, where we really scrutinize the clinical trials, the source provides context on utilization. While over 50,000 co-poisoned patients are seen in U.S. EDs annually, significantly fewer, over 16,000 between 1992 and 2002, were treated in North American hyperbaric chambers. This suggests a large number of potentially eligible patients are not receiving HBO.
Yeah, big gap there. A key claim from the source authors, supported by their review. Among patients treated with hyperbaric oxygen, both mortality and neurocognitive morbidity are improved beyond that expected with ambient pressure supplemental oxygen therapy.
The source notes there are 6 published randomized clinical trials for acute CO poisoning, but with conflicting results. This is often the focus of debate in the literature, isn't it?
It really is. Let's look at some of these. The study by Raphael et al. Found no statistically significant benefit when comparing HBO to normobaric oxygen. However, the source lists several limitations that weaken its conclusions.
What were those limitations again?
Significant ones. Nearly half the patients were treated more than 6 hours after exposure. The HBO pressure was only 2 atmospheres absolute, which, as we discussed, may be suboptimal for some mechanisms. There were no neuropsychological outcome measures. In only mildly poisoned patients, none had loss of consciousness were included. These methodological issues really cast doubt on the negative finding.
Okay, then there was a follow-up study.
Right, a large cohort study. It randomized patients without loss of consciousness to normobaric oxygen, or 1 HBO session, and patients with loss of consciousness to 1 or 2 HBO sessions. The HBO pressure was still 2 ATA.
And the outcomes were somewhat surprising, right?
They were. In patients without loss of consciousness, recovery rates were similar between normobaric oxygen and 1 HBO session. In patients with loss of consciousness, recovery was actually lower in those receiving 2 HBO sessions compared to just 1 session, 47% versus 68%.
Which is weird. How does the source explain that?
Well, the source criticizes these trials again for potentially underdosing HBO by using only 2 ATA. That mechanistic data suggests higher pressures, over 2 ATA, are needed for maximum inhibition of inflammatory adhesion molecules, a key non-COHB benefit. Maybe 2 ATA just isn't enough pressure, especially as given multiple times. Or maybe the sedation used, diazepam, played a role. It's not entirely clear.
Okay. In contrast, the studies by Ducasse et al. And Tom et al., which were prospective randomized trials treating patients within 6 hours at higher pressures, 2.5 to 2.8 ATA, both found significantly better outcomes with HBO compared to normobaric oxygen. The source notes a limitation of these studies was lack of blinding.
Then there's a blinded, randomized controlled trial from Australia mentioned, which showed no improvement in outcome at hospital discharge with HBO compared to conventional, prolonged normobaric oxygen. However, the source lists several significant methodological issues limiting confidence in this trial's negative result, too.
Right, let's recap those limitations for the Australian trial. They didn't report 1-month cognitive outcomes, only discharge outcomes after a few days. Poor 1-month follow-up, only 46% returned. The control group received unconventional, prolonged normobaric oxygen for 3 to 6 days. Cluster randomization was used, no intention to treat analysis was performed, and the neuropsychological test couldn't distinguish depression from cognitive dysfunction in a patient population with a high rate of suicide attempts.
That's a lot of issues that make it difficult to accept its negative findings at face value regarding long-term outcomes.
Agreed. Finally, the source highlights a double-blind, randomized controlled trial that did meet all elements of the consort statement, a standard for reporting clinical trials. This trial, likely the one referred to as HBOT-12, demonstrated a significant reduction in 6-week neuropsychological sequelae rates in patients treated with hyperbaric oxygen, 25% sequelae with HBO versus 46% without. That's a big difference.
A statistically and clinically significant difference. And the protocol in this positive HBOT-12 trial involved 3 HBO sessions within 24 hours, an initial 150-minute session with 60 minutes at 3 ATA, followed by 2 subsequent 120-minute sessions at 2 ATA.
In the HBOT-12 trial, pre-chamber cerebellar dysfunction was associated with worse outcomes, but HBO was still effective in reducing sequelae even after accounting for this. And the favorable influence of HBO was maintained through 12-month follow-up.
The source mentions another sham-controlled trial comparing 1 HBO session, 3 sham sessions, and 3 HBO sessions, finding no difference in outcome between interventions. The results of this trial, if interpreted in isolation, might support treating patients just once, which aligns with the trial comparing 1 versus 3 sessions we mentioned earlier.
Right, adding to the confusion about the number of sessions. This leads to differences in clinical practice. Some advocate for daily HBO until symptoms plateau, analogous to decompression illness treatment, supported by case series but not randomized trials for CO poisoning specifically.
So, despite the conflicting data from various trials, the source highlights the American Heart Association's recommendation. Based on their classification system, hyperbaric oxygen is recommended for patients with acute CO poisoning as a Class 1 recommendation strong. This is based on level BR evidence.
And what does level BR mean again?
It means it's supported by one high-quality randomized trial, presumably HBOT 12, two moderate-quality randomized trials, a supportive meta-analysis, and significant animal research. It acknowledges the mixed trial data, but weighs the positive evidence and mechanistic rationale heavily.
The source briefly notes that adjuncts to HBO, like granulocyte colony stimulating factor or steroids, are being explored but lack clinical trial evidence at this time.
Okay, let's try to summarize this complex evidence landscape. We see many more patients in the ER than receive HBO. The authors believe HBO improves mortality and neurocognitive morbidity compared to normobaric oxygen. There are 6 RCTs with conflicting results. The trial showing no benefit, Raphael, Australian, often had significant methodological limitations, lower pressure, delayed treatment, poor outcomes assessment, questionable controls, poor follow-up. The positive blinded trial, HBOT 12, used a multi-session protocol with a higher initial pressure and showed significant benefit for neurological sequelae. The AHA's Class 1 strong recommendation reflects the weight of this positive evidence, mechanistic data, and animal studies, despite the presence of negative or limited trials.
Okay, here's a board-style question. According to the source, what is the American Heart Association's recommendation strength and evidence grade for the use of hyperbaric oxygen in acute carbon monoxide poisoning, and what types of studies support this recommendation?
The source states the AHA recommendation is Class 1 strong, supported by level BR evidence, which includes one high-quality randomized trial, two moderate-quality randomized trials, a supportive meta-analysis, and significant animal research.
Perfect. That's the official stance presented by the source.
All right, final mega recap of the HBO evidence base. We noted the gap between ED visits and HBO treatments. The source authors conclude HBO improves mortality and neurocognitive outcomes over normobaric oxygen. We dissected the conflicting RCTs, highlighting limitations of negative trials and the strength of the positive HBOT 12 trial, multi-session, higher pressure, as providing the best evidence for reduced sequelae. The AHA's Class 1 strong recommendation based on level BR evidence supports HBO use for acute CO poisoning, reflecting the totality of evidence including mechanistic and animal data.
Okay. Moving into utilization review and optimal timing, the source reiterates that the optimal pressure, number of HBO treatments, and the maximum time delay after poisoning for effective therapy are still subjects requiring additional study. These are ongoing questions.
Yes, still some unknowns. Based on the positive randomized trials, the source states that dosing between 2.5 and 3 atmospheres absolute is recommended, leaning towards the higher pressures used in some successful studies, like TOM or HBOT 12.
There's a clear disconnect noted. While the majority of hyperbaric centers treat with a single HBO session, the best evidence for reduced cognitive sequelae cited by the source is for 3 treatments within 24 hours from HBOT 12, and some practitioners do follow this protocol.
The trial comparing 1 versus 3 sessions, while negative, had specific limitations, single-center, specific patient population, which might contribute to the uncertainty regarding optimal session number. It didn't necessarily disprove the benefit of 3 sessions in all patients.
The optimal timing window for HBO is also unclear. Animal data suggested an optimal time of 5 hours. In the HBOT 12 trial, over 60% of patients were treated within 6 hours, the rest within 6 to 24 hours. But the study wasn't powered to definitively say whether treatment after 6 hours is less effective.
So whether HBO is beneficial after 6 hours from poisoning is technically unknown based on this source's review of trials. However, given that brain injury can evolve, the source suggests it's reasonable to treat as soon as possible, up to 24 hours, or potentially even longer if the patient is still symptomatic. Most practitioners won't treat beyond 24 hours, though some report success in case series with longer delays. It's a gray area.
Figure 1 in the source provides a treatment flowchart summarizing the proposed approach. Let's walk through the main decision points verbally.
Okay. It starts with suspected CO poisoning. First question, cardiac arrest with CPR. If yes, HBO is not indicated according to this chart. If no, you evaluate, treat, and importantly, identify others who might have been exposed.
After initial evaluation, the next key question relates to timing. Has it been less than 2 weeks since CO exposure stopped? If yes, then the next question is, has it been less than 24 hours since exposure stopped?
Okay. If it has been less than 24 hours, the flowchart directly recommends HBO using the 3 ATA going to 2 ATA protocol, referencing the HBOT-12 protocol. This suggests acute treatment within the first day is strongly favored if the patient is symptomatic.
Right. What if it's between 24 hours and 2 weeks since exposure stopped?
Then the flowchart asks if there are continued symptoms or deficits. If yes, it still recommends the same HBO protocol, 3 ATA 2 ATA. This suggests considering HBO for persistent symptoms even outside that initial 24-hour window, up to 2 weeks post-exposure.
Interesting. And if it's been more than 2 weeks since exposure stopped?
Then the flowchart again asks if there are persistent or new deficits or symptoms. If yes, the pathway is to educate on prevention, follow up, treat symptoms supportively, refer for specialty care as needed. And then it says consider additional HBO. This implies HBO is a consideration even for chronic persistent issues, though as we discussed, the evidence basis for this is less clear from randomized trials.
The flowchart notes clarify definitions, evaluation steps, standard oxygen, referral triggers, and reinforce that 3 ATA protocol as proven effective for reducing sequelae. It also mentions that some advocate for daily HBO until a clinical plateau is reached for persistent symptoms, reflecting that practice variation.
And the source provides useful referral information. The Divers Alert Network, DAN, can refer to hyperbaric chambers, and the Undersea and Hyperbaric Medical Society, UHMS website lists accredited facilities.
Okay, let's discuss the discrepancy between the evidence suggesting multi-session HBO, like HBOT-12, and the common practice of single sessions. What might drive this?
Well, factors likely include logistics transporting critically ill patients multiple times, chamber availability, staffing for multiple dives isn't trivial, cost and insurance coverage can also be barriers, and perhaps some practitioners are still influenced by the trials that didn't show benefit from more sessions, leading to genuine uncertainty about the optimal frequency for every patient.
And the challenge of the therapeutic window. Animal data suggests promptness is best, 5 hours, but human trials couldn't strictly test this narrow window. The flowchart suggests treating acutely within 24 hours if symptomatic, and potentially considering it later for persistent symptoms, reflecting the clinical ambiguity beyond the acute phase.
Exactly. Okay, mega recap for utilization and timing. There's a gap between ED visits and HBO use. Optimal dosing, pressure, sessions is debated, but the source leans towards 2.5 to 3 ATA pressure and highlights HBOT-12's 3-session protocol within 24 hours for reduced cognitive sequelae, contrasting it with common single-session practice. The optimal treatment window isn't definitively known, though earlier is likely better, and the force suggests treating up to 24 hours or possibly more if symptomatic based on the flowchart. We've walked through the flowchart summarizing the source's proposed clinical pathway based on time since exposure and symptom presence.
Section 18 briefly addresses the cost impact of HBO. The thwart states that the cost of acute hyperbaric oxygen therapy is modest, especially when compared to the potential long-term costs. Prevention of morbidity from neurologic and cognitive sequelae, which can be profound and lifelong, represents a substantial cost savings to the healthcare system and society by avoiding long-term care, lost productivity, and chronic medical expenses.
Yeah, it makes a compelling economic argument that the upfront investment in HBO, if it prevents even some of those devastating long-term outcomes, is likely justified financially by avoiding much larger downstream healthcare and societal costs associated with chronic disability from co-induced brain injury.
Makes sense. Now, a crucial and often co-occurring complication. Carbon monoxide poisoning complicated by cyanide poisoning. This is particularly relevant for victims of fires, right? As burning synthetic materials release cyanide.
Absolutely, a deadly combination. The source highlights the interaction. In combination, CO and cyanide may exhibit synergistic toxicity, meaning their combined effect is worse than just adding their individual effects together. And severe cyanide poisoning alone is rapidly fatal.
The diagnostic challenge is significant. Symptoms of mild to moderate cyanide exposure, headache, nausea, confusion, altered mental status. Cardiac problems overlap considerably with CO poisoning symptoms. Clinically distinguishing them acutely can be very difficult.
Yeah, they look very similar initially. And unlike CO, which can be quickly diagnosed using co-oximetry to measure COHB, current laboratory tests for cyanide concentration cannot be performed quickly enough to confirm the diagnosis before urgent treatment is required.
Yeah.
So you often have to treat based on clinical suspicion.
What are the clinical clues pointing towards cyanide co-poisoning in fire victims?
The source mentions altered mental status and the presence of soot in the mouth or mucous membranes. These suggest significant smoke inhalation and raise the suspicion for cyanide, along with CO.
The source briefly explains cyanide's mechanism. It binds to the enzyme cytochrome C oxidase in mitochondria, blocking ATP production and causing cellular hypoxia and metabolic acidosis. This is a different direct cellular toxicity mechanism than CO's, although both ultimately cripple cellular respiration.
Right. Initial management for suspected cyanide poisoning, after supportive care like ventilation and blood pressure support, involves administering a cyanide antidote. The source notes several exist but vary in availability. Hydroxycobalamin, or sodium thiosulfate, are considered the antidotes of choice, being effective with lower risk of serious side effects compared to others.
Older antidotes like amyl nitrite and sodium nitrate induce methemoglobinemia to bind cyanide. However, the source points out a critical problem with these nitrate-based antidotes in the setting of co-occurring CO poisoning.
Right. Inducing methemoglobinemia to treat cyanide is contraindicated when CO poisoning is also present, because methemoglobinemia further impairs the already compromised oxygen-carrying capacity of hemoglobin due to the COHB binding. It would just worsen the overall oxygen delivery problem. You don't want to do that.
Yeah. A practical clinical point. Administration of hydroxycobalamin before measuring COHB by co-oximetry may interfere with the reading and yield unreliable results. Important to consider for diagnostic timing.
The source discusses the role of HBO in pure cyanide poisoning. Clinical reports are infrequent and inconclusive, though some suggest benefit. There are no controlled trials specifically for pure cyanide poisoning or for CO poisoning complicated by cyanide. However, a trial of hydroxycobalamin used HBO concurrently without reported adverse interactions, so they don't seem incompatible.
Theoretically, hyperbaric oxygen might help in cyanide poisoning because it's known to preserve ATP production, which cyanide inhibits. However, the complex interaction between CO-cyanide and nitric oxide regarding cytochrome C oxidase isn't fully understood, and HBO's exact role here is still unclear.
Animal data on HBO for cyanide is mixed. Early work showed improved survival and restored brain electrical activity. But another murine study found HBO wasn't better than atmospheric oxygen at enhancing effects of nitrite ethyl sulfate antidotes. More recent rat studies show HBO and hydroxycobalamin comparably reduced brain lactated glucose markers, and HBO provided added benefits like increased brain and tissue oxygen and reduced respiratory distress. So, some positive signals there.
An interesting observation in rats. HBO increased circulating cyanide concentration after administration, though the mechanism is unclear and not reliably seen in humans. Hydroxycobalamin acts mainly extracellularly, while cyanide distributes widely.
Research is looking into dual antidotes. A synthetic porphyrin showed promise against both CO and cyanide in rat studies, but human trials are needed. Again, future stuff.
So, the source concludes this section by stating that, based on the evidence, HBO is not supported for pure cyanide poisoning at this time. But HBO is indicated for acute CO poisoning, including mixed poisoning with cyanide. Clinically, HBO is widely used in mixed cases. A StatPearls review is referenced as discussing HBO for cyanide toxicity, suggesting it's becoming more integrated into the conversation around cyanide treatment, too.
And the utilization review for mixed poisoning simply states the treatment protocol is the same as for CO poisoning alone. You follow the CO protocol, which includes HBO when indicated based on the CO criteria.
The cost impact for mixed poisoning is deemed justifiable. Given the severity, mortality, and potential morbidity reduction, using HBO for a few treatments in these critically ill patients is considered reasonable from a healthcare cost perspective.
Let's just quickly discuss the clinical challenge of mixed co-cyanide poisoning again. The symptom overlap means you can't differentiate clinically. The slow cyanide test means you have to rely on suspicion, fire exposure, altered mental status, SUD. You might initiate treatment for both, and choosing the right antidote, hydroxycobalamin thiosulfate over nitrites, is critical due to that contraindication with CO.
And why is HBO indicated for mixed poisoning even without specific trials for the combined state?
Likely because its proven benefit in CO poisoning is strong, and it has theoretical benefits in cyanide poisoning, ATP preservation, even if not proven clinically for cyanide alone. Given the synergistic toxicity and high mortality, applying a therapy proven for one component that also potentially benefits the other seems a rational clinical approach in these dire situations.
Okay, here's a board-style question. A patient is rescued from a house fire with altered mental status and soot around their mouth. What two toxins should be highly suspected, what immediate diagnostic challenge exists compared to just carbon monoxide poisoning, and which class of cyanide antidotes is contraindicated in this specific mixed poisoning scenario, according to the source.
Okay. Carbon monoxide and cyanide should be highly suspected. The diagnostic challenge is the slow availability of cyanide testing compared to rapid COHB measurement. And the class of cyanide antidotes contraindicated with concomitant CO poisoning are the nitrate-based antidotes.
Perfect. Recognizing that dual threat and the antidote contraindication is vital in fire victims.
Okay, mega recap for mixed CO-cyanide poisoning. Common in fire victims due to burning synthetics, causing synergistic toxicity. Symptoms overlap, making clinical diagnosis difficult. Cyanide testing is slow. Hydroxycobalamin or sodium thiosulfate are preferred antidotes. Nitrite-based antidotes are contraindicated with co-occurring CO due to methemoglobinemia risk. While no trials exist for mixed poisoning, HBO is indicated based on its benefit for CO poisoning and theoretical benefits for cyanide. The protocol is the same as for CO alone. Cost is deemed justifiable given the severity.
Section 20 briefly addresses smoke inhalation. The source notes that based on anecdotal reports in animal trials, hyperbaric oxygen might possibly benefit the pulmonary injury from smoke inhalation itself, separate from CO or cyanide.
Yeah, just the lung injury for the smoke itself. However, the current evidence status is clear. There is insufficient evidence to support hyperbaric oxygen for smoke inhalation unless the patient also has concomitant carbon monoxide poisoning. So if it's pure smoke injury without significant CO, HBO isn't routinely recommended based on this source.
These patients are often critically ill, requiring advanced support. The source adds a practical consideration. Only hyperbaric medicine centers equipped with critical care expertise can manage these complex patients within the hyperbaric environment. You need ICU capabilities in the chamber setting.
Right. Why might HBO theoretically help pure smoke inhalation? Perhaps by reducing inflammation or edema in the lungs, or preserving cellular function and damaged airway tissue? The source doesn't really elaborate on mechanisms here.
And the lack of sufficient evidence means we need more rigorous clinical trials looking specifically at smoke inhalation injury without confounding by FeO. It's a challenging population to study given the complexity of their injuries.
Absolutely. This ties into managing multi-trauma patients from fires. The decision to use HBO for co-cyanide happens within the context of managing burns, other trauma, and the pulmonary insult from smoke. It requires a center capable of managing all these components safely.
Finally, Section 21 acknowledges the contributors to the source material, Dr. Claude Piantadosi for reviewing Table 3, and Kayla DeRue and Rosemary Zemnick for writing assistance.
Right.
So what does this extensive deep dive mean for you, the specialist clinician listening? We've journeyed through the surprising prevalence of CO poisoning, peeled back the layers of its complex pathophysiology that goes far beyond simple oxygen deprivation, explored the wide and often delayed spectrum of symptoms, and navigated the clinical management guidelines, including the nuances of patient selection and the debate around optimal hyperbaric oxygen protocols.
Yeah. We've confronted the challenges of mixed cyanide poisoning in fire victims, the need for specific antidotes, and the role of HBO in that context. And we face the sobering reality of long-term sequelae, the persistent neurological deficits, the increased risk of chronic medical conditions, and the impact decades later underscoring the vital need for long-term follow-up, and recognizing that HBO, while beneficial, doesn't eliminate all risk.
Here's where it gets really interesting and requires critical thinking, I think. The source presents evidence strongly supporting hyperbaric oxygen for acute symptomatic CO poisoning, particularly for preventing neurological sequelae, with specific protocols like the 3-session approach from HBOT 12 showing benefit. Yet it also highlights that common clinical practice often involves single sessions and notes ongoing debate regarding optimal timing and pressure.
Right. So given the potential for devastating lifelong neuropsychiatric and medical consequences of CO poisoning, and the evidence suggesting that hyperbaric oxygen, when delivered appropriately and early, can reduce this risk. How do we, as the medical community, effectively bridge the gap between the best available evidence, even with its acknowledged complexities, and conflicting trial results and consistent, high-quality clinical practice to ensure that every patient at risk receives the most effective care currently possible? That's the lingering question, isn't it?
It really is. A provocative thought to end on. This concludes our deep dive for today.